Okay, so welcome everybody to the next session for today's program. As you can see, this is a session which is about local therapies primarily. The first half of which has an ophthalmology emphasis, and the second half more specifically about radiation therapies. So it's my pleasure to introduce our first speaker, Dr. John McKenzie. He's very well known to the Australian audience, a leading ocular oncologist, and he's head of ocular oncology at the Royal Victorian Eye and Ear Hospital in Melbourne. Currently, he's chairing ARANSCO, so the Australian College of Ophthalmology, New Zealand College of Ophthalmology group, which is developing an Australian national treatment pathway for uveal melanoma patients. And he's going to tell us about that project this morning. Thanks very much, John.
Hi, Claire. Hopefully you're seeing my screen now, so I'll start my slideshow. Can you hear me, Claire?
Yes.
Yes, great. Okay. So I'm John McKenzie. I set up the Ocular Oncology Clinic at the Eye and Ear Hospital back in 1990 when I returned from a fellowship in London. I worked for many years with Willie Campbell, and we've now got two other subspecialty trained ocular oncologists in Dan and Rod.
John, can I just introduce, we're seeing your whole presentation rather than the slideshow. Is it possible to change that? As in we can see your notes and everything.
Just a sec.
If John just selects the swap delays at the top of the screen, that should remedy.
So swap
delays. So there's three options there.
Swap displays, is it?
Swap displays, sorry.
Yeah. Just there, John. Oops. Bring back your mouse to the right, little bit. There it is. Yep, just there. That's it. Swap displays. Can you see that? Or
I've got your screen sharing. I can't see swap display. Move to bottom.
It might be on your other screen, John.
My other screen is Maxi. I will close it off and just have to see if I can start. I don't, unless I pull out my second screen, I might be able to, if I do that, I might be able to
That's better.
That's better. Yeah. Okay. So it's a dual screen problem. So we work in a multidisciplinary but standalone eye hospital called the Victorian Eye and Ear Hospital. And I'll go through some of this because whilst a large part of the audience are involved in the field, we also have hopefully a number of people from other areas, including our patient group. And the current team has expanded beyond just the clinicians. We've now got other ophthalmology people. We've also got a data manager and as of Friday, a nurse coordinator, along with having what we call partners. In particular, Claire, who's chairing the session today, Anthony Joshua, Damien Key and Mark Shackleton are our primary people involved there. Now, in our practice, we triage a number of conditions. Choroidal melanoma makes up about 3/4 of what we do, but we also do ocular surface and adnexal and periocular tumours. We've got a wide range of treatment modalities. Primarily ruthenium plaques would be our mainstay of treatment. We also order in iodine seeds when we need them. And through Claire at Peter Mac, we've got access to stereotactic radiation. Enucleation is also a very significant part of what we do there. And down the bottom, you'll see that we do use lasers, but we haven't used them all that much. that perhaps new treatment modalities such as the Aura Bioscience system will help that out. This is just to really explain where we are, and this is an Earthwatch map of where the lights are on. You can see Melbourne, Sydney and Brisbane are fairly bright. There's a couple of spots over in Perth and Adelaide. And of course, New Zealand's got a fairly well distributed population. If you look at where people live, it's pretty much around the coasts. The grey bits are where no one lives. And so in Australia and New Zealand, we've got ocular oncology centres based from Perth to Brisbane around the coast. We've got Peter Haddon in Auckland, and of course up in the Pacific Islands we also have I suppose a clinical referral area which we need to attend to, particularly through our New Zealand colleagues. At the Ioneer, as I said, we had just myself and Willie Campbell, and then Willie retired from the ocular oncology. So we had to do something about developing a team. And we developed what we call an ideal pathway. That was back, which we finished in 2019. And that was really trying to get decide on the groups of people that you needed to have within a clinical team. That took about 5 years with the assistance of an integrated cancer service. And then they did a gap analysis. And of course, they'd found all of them, which was that we didn't really record anything in a format that you could put into any sort of database. This was very much an institution-based, hospital-based program, because the eye hospital is in each place is very different. We talked about the development of an MDM, which we've gone on to. We've maintained or developed true partnerships with the Alfred and Peter Mac, and we're trying to then move on to benchmarking, and particularly the use or the introduction of our data manager and our nurse coordinator. From that, we hope to evolve what are the current Australian guidelines, which is an NH and MRC document from 2008. And we hope to use as the basis of the RANSCO guidelines, which is what we used for the basis of the hospital guidelines, which was the UK guidelines, which were chaired by our earlier speaker, Paul Nathan. What we're aiming through RANSCO is to, first of all, get a code of practice for the ophthalmic group, but we're then trying to lead on to what we call optimal care pathways. And they were initially done for what I call the non-rare cancers. And they were started off in Victoria, but quickly became an Australia-wide pathway, which then specifies really the clinical path that a patient will take. And they both have a professional as well as a consumer guide attached to them. These are the ones that are currently in use, although a number of them have been since updated, as have the UK pathways as well. It's just a reference to a 1990s study which we did with PH and RDC funding, which was an Australia-wide study looking at the incidence of melanoma throughout Australia. We found, not surprisingly, that it's pretty much the same over the whole of the country, and that this was the first time that we as a country had collaborated to try and produce data. We didn't, however, have a pathway of treatment. It was really just looking at diagnosis. We've then gone on to say, well, if we're going to have a pathway, one of the big things that we need is to have data. And we started off with what we call the Victorian Ocular Oncology Registry, which has been really pushed by Rod O'Day, whose name is down there as the principal investigator. That's starting off as a paper file in a Red Cup database, because this was the first thing that we could get ethics approval on. What we're aiming for as part of our pathway is to develop an open access database, and we're going to do this at the Safe Sight Institute, and it's set up as the Fight Tumour Blindness. It's got a headline there, but the back build is still currently being done. The idea of this is that it will match both our Victorian registry and also the data fields of the international database, which we feel is much more oriented to systemic management. And I think that what we're trying to do as ophthalmologists is improve our clinical care of what we do, because I think that's very important for where it leads patients. They need to know what their diagnosis is and where they're going to go into in regard to systemic management. We can also start using this data to benchmark our clinic. And this is the first time that we've done an audit, and it's the calendar year 2021. What it shows is that we've had 94 patients that we've done procedures on, of which 76 are uveal melanoma, 51 treated by ruthenium, 4 by iodine, and 21 by enucleation. There's always a couple of unknowns when you're trying to do this retrospectively. You look at tumour size versus treatment types. Clearly the plaques are down the smaller end, the enucleations are up the top end, and one of our consumer patients was in that enucleation group who spoke earlier. We can then, on a very simple basis, actually just compare what our treatments are with other centres, and this is an example of being able to do this with the group in Liverpool, and we'll as we develop the registry, we'll be able to do that, hopefully with an Australian focus. The aim of our database, as I said, which is going to try and form part of our clinical care pathway, is really focusing on diagnosis and staging. And the main system that's done is the AJCC, which is really based on an anatomical staging of tumours, and therefore creating a systemic risk analysis based on that. It describes tumours, whereabouts they are at the front or the back of the eye, whether they've got any extraocular extension, and whether there's any ciliary body involved in those. All those things increase the risk based on anatomical features. Cytogenetics, and which can include gene expression profiling, which we don't really do much of in Australia, can also further refine those risks. And we then need to divide people up into low risk, classically the AJCC T1 group. And there we're saying that there's a less than 10% systemic risk. There's an intermediate risk, which we haven't really put figures on, which have both AJCC staging as well as various other parts which will come from tumour analysis. And of course, our high-risk groups, which are the larger tumours in AJCC staging, as well as monosomy 3 being the main pathological features that we look at. So what is our role? Our role is to diagnose and manage the primary treatment. It's to help in this risk stratification, and that's where our MDMs are very important. We're trying to have an MDM at diagnosis to discuss treatment, and then at 3 months to discuss what their systemic management will be. It's also that we need to be promoting enrolment of our patients in trials for good data for future management. One of the next talks is going to be talking about nevi, and there, within the Liverpool group especially, there's a number of lesions which they had diagnosed as melanomas but observed. In the COM study, the metastatic rate was melanoma for these small lesions under 2.5 millimetres. There's a 1% melanoma related risk. So the question comes, is that safe to observe, or is it something that we need to be looking at? So part of our clinical care pathway is not only melanoma, but suspicious nevi. I think that's a very important part that we need to include within our pathway and within our within our database. So this is just an example of a lesion which has been seen as a nevus. 3 years later, it's a large melanoma, which presents very significant treatment and issues, as well as systemic risk issues. So just to go through a little bit of where we're up to with local treatments, brachytherapy was first done to an eye back in 1930 in St Bartholomew's Hospital on a child with retinoblastoma. These are just the original drawings of the tumours, a seed of radon placed in the eye, and this was the eye 30 years later, which was largely wiped out by the side effects of the radiation. They then went on to develop further plaques, both iodine and ruthenium. Ruthenium is the one in the top, at the top here, which we would use mostly. Iodine we generally try and reserve for larger tumours only. This is an example of COMS plaques, which range from small, 10 millimetre up to 22 millimetre, and there's a range of ruthenium plaques in terms of size that we can use. So this is stealing a slide from Mark Shapton. There's still a lot that we need to do as ocular oncologists. There's a lot that we need to collaborate with our systemic colleagues, and hopefully the development of our pathway and its associated database will allow this to happen. So I'm going to stop sharing. Yep.
Thanks, John. Shall we save the questions to the end? I think next we're going to hear a pre-recorded talk from Mandeep Sagoo. Mandeep is the head of ocular oncology at Moorfields in London. He's a professor of ophthalmology and ocular oncology at UCL and specialises in both adult and paediatric eye tumours.
Thank you, Mandeep. He's obviously asleep at the moment, so we might save some questions for the end that Rod might be able to help us out with. Your name's on a few of those papers, Rod.
Oh, Mandeep's he's calling in from holidays very early in the morning. So,
oh, great. Okay, so we'll move on to the next talk. Oh, there he is. Hello, Mandeep. Thank you. I think we're going to save questions till the end of the session, though. So we'll move on to Lauren's talk. So this is another pre-recorded talk from Dr. Lauren A. Dalvin, who's an ocular oncologist at the Mayo in the US. She has a dedicated practice in the diagnosis of treatment of both intraocular and ocular tumours. And her talk today is on adjuvant systemic therapy for conjunctival melanoma.
Thanks, Lauren. That was a fantastic presentation. What tricky cases and with great outcomes. I'm sure there'll be questions coming up after we hear from Camille. Camille works with her father she's an ocular prosthetist in Victoria. She has been doing it for a decade, her father for many more decades before her. And she's really the reason that we can say honestly to our patients that they may have been sitting in the waiting room with the person with prostheses and they won't have noticed it. She and her team give huge amount of comfort to the patients who, before they have enucleation, know that they're going to have a good cosmetic outcome.
Thank you, Rod. Can everyone hear me okay? I think we're good.
All good.
Cool, thanks, Rod. Artificial eyes, prosthetic eyes, glass eyes, ocular prostheses, fake eyes. I'm sure that you've all heard some of these terms, but what are they? Who makes them? And why would somebody need one? My name is Camille Loyer. I'm an ocularist in Melbourne, Australia. Firstly, I just wanted to thank Jessica and Neil for their contribution from a patient's perspective. I think that was really, I really appreciated that. And Neil, thank you for your kind words as well. It was a pleasure. Artificial eye prostheses are made by people who have undertaken an apprenticeship under an experienced ocularist. I trained with my dad, Patrick, for 9 years. Today, I'm going to speak to you briefly about prosthetic eyes. I know our audience today is a little bit mixed, which is awesome. So I've left a little bit of extra time at the end for questions in case I haven't covered a topic that you'd like to know a little bit more about. And my email's at the bottom there, so please don't hesitate to reach out as well. History of the artificial eye. Let me take you back a few thousand years. Artificial eyes were made from clay, bone, gold, bitumen, and ivory, and were sometimes worn externally to the socket. In around the late 16th century, glass became the material of choice, but then during World War II, glass was no longer able to be exported from Germany and other materials needed to be found.
Hey, Camille, we just can't see your slides.
Let's try that again.
Yep, there we go.
That's better?
Yep.
Sorry.
No.
Not an expert at this Zoom thing. Here we go. That's better. So after World War II, when glass was not being exported anymore, the fields of dentistry and ocularistry worked together and the acrylic prosthetic eye was born. While they are often called glass eyes, ocular prostheses are usually made from medical grade acrylic plastic, with the exception of a few countries such as Germany and Switzerland who still use glass as well as acrylic. I'm really in awe of the skill required to make a glass prosthesis. It's really a beautiful art to watch. Here are some photos to quickly show the progression of artificial eyes, the two on the left dating back many thousands of years. And then on the right, you can see some glass prostheses. Here are some prostheses that I have made. These are all made from acrylic plastic. I find the benefits of using plastic over glass are that you can mold the prosthesis to a specific shape. Acrylic is less fragile than glass and it can be polished, repaired, or modified if required. As you can see, these prostheses are all different shapes and curves based on the shape of each individual's eye socket. They look a little bit like shells. So why might somebody need an artificial eye? We see clients of all ages in our practice, sometimes as young as 1-week-old babies. There are a number of reasons why someone might need to wear an artificial eye. Some are congenital, such as retinoblastoma and microphthalmia, and others occur later in life. We see adults who have had an accident or the eye loss may be due to disease, one of which that we see is obviously ocular melanomas. We see approximately 15 new clients in our practice per year who have had their eye removed because of a melanoma. After diagnosis, in cases where the best course of action is an enucleation, which is the removal of an eye, the surgeon replaces some of the volume in the socket with a small spherical implant, which you can see in the yellow on the image on the left. The muscles are attached to this, which allows the prosthesis to move. Many people think an artificial eye will look like it's a bit starey, but this is really the case now that there are more advanced surgeries and custom prostheses are now the standard. The implant and prosthesis almost work together as a ball and socket joint, moving together as the accompanying eye moves. The photos on the right show an example of the artificial eye shape when paired with a surgical implant. Artificial eyes are all shaped differently based on an impression taken of the socket. And I think most people expect that they will look a little bit like the image on the left, but we don't choose them from a drawer. Everything's custom made for each client, which you can see on the right. These images here show how the prosthesis can move with the accompanying eye. So, purpose of an artificial eye. The purpose is to create a balanced facial appearance by restoring the colours and volume that have been lost. The prosthesis usually increases comfort in the socket as it encourages the eyelids into a more normal position. Though an artificial eye does not restore vision, many clients report feeling more balanced when wearing their prosthesis. I think this is related to the sensation of the eye being full and the eyelids opening in the same way on both eyes. The artificial eye serves several roles in comfort, appearance, facial and socket development, social interactions, and improving self-confidence. The artificial eye also encourages tears to flow more naturally in the socket, and the body is usually able to lubricate the prosthesis quite well. So how the prosthesis is made. An artificial eye can be made approximately 6 weeks following the enucleation once the socket has completely healed. The process of making an artificial eye consists of 3 visits to us. During these appointments, we take a mold of the eye socket, which you can see up on the left. We create a shape to match, which is below that image, hand paint the color of the iris and the sclera, all while the client's with us. Then it takes a few days for the prosthesis to be cured and colored before the client returns for their final fitting. Here are some results. This man's prosthesis is the left eye, so right of screen, right eye, left of screen, left eye, right of screen. Realize they're all blue, but yes, we do make all colored prostheses. So caring for the prosthesis. When well cared for, an artificial eye will last decades. However, they do need to be replaced more frequently than that, as the body will change gradually over time. This includes the eye socket and eyelids. Changes in the socket mean that after approximately 5 years, the prosthesis won't fit as well as it once did, and a new prosthesis might need to be made. We see children much more regularly to ensure that the soft tissue and bony orbit develop as symmetrically as possible, and the presence of a prosthesis stimulates the body to grow and encourage development on that side of the face. Acrylic prostheses can be polished and repaired as required. You can see me polishing the prosthesis on the left, and the general recommendation is having the prosthesis polished at least once per year. Contact lens solutions can be used to clean the prosthesis, as well as using lubricating eye drops as required. Polishing and cleaning are required to remove any protein buildup on the surface of the plastic and to reinstate the shiny surface. This ensures that the eyelids are blinking over a smooth prosthesis and helps to maintain the health of the socket and eyelids. The prosthesis usually can be worn for a few months before cleaning is required. Here are a few images to show you how the prosthesis is removed and reinserted, which is relatively straightforward, and I have lots of young children who are able to do this themselves, which is really cool. Helping your artificial eye wearing patient. I encourage my clients to wear glasses for several reasons. Glasses can assist in protecting the good eye, and they can provide a slight distraction from the prosthesis. So you can see my eyes, you can still see my eyes, but your brain is kind of registering the frames as much as the eyes behind. So I'm not suggesting hiding behind glasses, but using them as a tool to create a little bit of a distraction. Just a little note, it's important to match the lenses on both sides. Even though there's no vision on the prosthetic side, we want the prosthesis to be magnified in the same way as the natural eye. And an optometrist can also play with different prisms and magnification to improve the appearance of an artificial eye if there are differences in the eyelid shape and size. So there's a few of my little clients wearing their glasses. They all have a prosthetic eye. Losing an eye can be a terribly traumatic and stressful experience for the patient and their loved ones. And I can't pretend to know how that feels. But talking with my clients about what the prosthesis does for them, I know that with prosthetic rehabilitation of the socket, a person who has lost their eye can live a happy and healthy life. The prosthesis plays an important role in a person being able to get back to doing what they were doing before they lost their eye. And our aim as an ocularist is to make something that is seen but not noticed, giving our clients confidence that they can go about their normal activities. I feel extremely privileged that I'm able to contribute to the healing of a person and that with a little piece of plastic, people can thrive after eye loss. And though a prosthesis does not give someone their vision back, patients report feeling whole again when they receive their artificial eye. Given some time to adjust to monocular vision, I witnessed my clients doing incredible things with little limitation. I'm not going to list everything that's possible to do with one eye because it really is almost anything. The one limitation being not being able to fly a fighter jet. I'll leave you with a little story. Recently, we had a young client who was nervous about starting her first year at school. And when we asked her why, she said she was worried about her new friends, that they would be sad that they couldn't have a special eye like her, which I thought was really gorgeous. Although losing her eye was a big hurdle in her life, her attitude shows that she's not defined by her prosthesis or limited in what she can do, and that people do live incredibly rich lives after eye loss. Thank you for your time, everyone.
Thanks, Camille.
Thanks very much, Camille. We're going to open the floor to questions now. We'll just wait for your screen to clear that away. Camille, I just have to say, I'm in awe of the work that you do. It's Claire Phillips here. I'm a radiation oncologist. So when I meet my patients who've got one of your eyes or your dad's eyes, I have to test myself. Can I guess which eye it is that's involved? And I know that you've massively improved the quality of life of those people with your amazing work. So on their behalf, I thank you very much. I think it's incredible. So we've already got
Claire,
some.
If you can tell, it's because us, the surgeons, have not done a good enough job replacing the volume.
We've got a couple of questions in the chat already, and I do invite the audience to add any more as we go along. So the first one is addressed to Lauren, and it comes from Damien, who's a medical oncologist, asking about a prospective study in your work with conjunctival cyst adjuvant therapies. The question specifically says, given how rare and individualized they are, do you think it would be possible to collect data or run a trial that could help confirm benefits and help open reimbursement in some countries, as a little additional point?
Yes, I think that's a fantastic question. You know, these things are possible, but challenging, as we're having a nice discussion and some comments from John McKenzie here in the panelist chat. Because treatment is so individualized and we're dealing with a rare disease, there are so many confounding factors if we're going to talk about outcomes of recurrence and metastatic disease. So it becomes really challenging to design the ideal study. But of course, I think if you had a large multi-center collaboration, there's definitely an opportunity to put together some data. You know, it may be the kind of thing that, for the best interest of the patient, because of different practices in different centers in different parts of the world, there may have to be some acceptance of a little bit of messy data, but to help get to a reimbursement and to help at least get some evidence for this, I think that would be a fantastic idea.
Thank you. Perhaps something that this international database may be able to achieve over time. Should we go on to the next question? Rod, shall I hand over to you?
It's for Camille. Does the surgical reconstruction take into account the development of the prosthesis or not? And if it does it matter?
I'm not sure I fully understand.
I think it's getting it towards the way the socket comes to you from us. Do we take into account, does how it comes to you alter the outcome for patients?
Oh, okay. Yes, it does. Having a large implant that's attached to the muscles makes a big difference in what I'm able to do. The prosthesis can be a lot thinner, which is reducing the pressure on the bottom eyelid, and we get more movement. In cases where there's no implant, I find there's obviously not much movement and quite a deep superior sulcus at times. It also affects how much the eyelids are able to close over the prosthesis, and that's something that's really important for comfort and lubrication. So yes, there's what I'm able to do is varied based on the shape of the eye socket.
Another one for you from Daniel is, for the benefit of the eye surgeons, would you mind sharing your impressions regarding the use of conformers in enucleation surgery?
Yeah, I love a conformer. Please use conformers. I find that we get better fornices when there's been a conformer. Sometimes there can be an ectropion or quite a lot of swelling in the lower half of the socket when there aren't conformers. Obviously, we'd have to have a parallel universe to see each socket with a conformer and without a conformer, but I find that generally a conformer will give better socket for me.
Okay, I think there's one more question for Camille. I might just finish the interrogation for you and then we'll move on to some systemic therapy questions. I think we've got time. It was a particular question from Bill Glasson about, do patients get any allergy or sensitivity to the acrylic material of the prosthetic eye?
Yeah, good question. A true allergy to the acrylic is very, very, very rare. I know my colleagues in Perth, they have a client that needs to take antihistamines before they do a fitting. They do everything in wax up until the very last stage. They try the prosthesis in very quickly and then they send it to Germany to be copied in glass. We haven't had the need for that. So some people tolerate the prosthesis better than others, but I don't think there's really a true allergy in most cases. And discomfort is usually a lack of lubrication, or perhaps the prosthesis hasn't been polished, so it's not as smooth as it could be. So usually a well-fitting prosthesis that's polished and well lubricated, most clients manage that really well.
Fantastic. I've one for Mandeep if he's still with us. Mandeep, you're using your artificial intelligence as a standalone assessment of a tumour. Is there any plan to use it to look for change over time and to more accurately monitor for that?
Thanks, Rod. I think our main focus is just as a standalone for primary diagnosis. I think we need to get that right before we can move on to looking at progression or monitoring. But I think the potential is there because we're so imaging based. I think, yes, that is entirely possible. Yeah, but I think we need to get the initial findings right.
Thanks very much.
There's a systemic therapy question here, which I think might be addressed to Lauren, but perhaps Damien's got some input as well. How durable is the response to adjuvant BRAF/MEK or immunotherapy in multifocal progressive choroidal melanoma or conjunctival melanoma, perhaps a CM? We have a patient with impressive local tumor regression, but brain metastases.
Yeah, it's a great question. You know, our data, our follow-up data at this point are so short that I don't know anybody has a definitive answer to that on a statistical level. I've certainly seen some long duration durable responses, but I've seen surprise recurrence as well. And I don't think anyone knows the correct answer either for, is 1 year of adjuvant treatment the magic number? That's kind of our standard go-to, but again, the evidence just isn't there yet.
Struggling with I have a question for Mandeep as well. You alluded to the potential for the moles approach for nevi assessment to be used more broadly than by specialist ocular ophthalmologists. Have you got as far as working out how you would disseminate that information more broadly?
So at Moorfields now, our triage system for working out how quickly we need to see patients and putting them into the correct clinic is based on mole scores. And so referring ophthalmologists or optometrists have to complete an online form with all the moles criteria in order to be able to refer. And that allows us instantly to see what the mole score is and whether we need to see them this week, or if it's just a nevus that needs a check, then that gives us a little bit more leeway. And I think that the patients also find it reassuring that, using this online tool, the optometrist or the referring ophthalmologist can say, oh, look, it's low risk, but we want the Moorfields team to have a look and advise. So I think by using it for triage, it is being rolled out. I hope you got all of that because I have a very poor connection.
Yes, we absolutely did. And that sounds like it's working very well already in the community use. I don't think we've got any other questions coming up at the minute. Oh, one last one for Lauren. Anti-PD-1 monotherapy or combination ipi-nivo for unresectable conjunctival melanoma?
Yeah, for primary tumor alone with no metastasis, our practice has favored pembrolizumab monotherapy. We've had good success. Again, I think this is all a great study. It's almost too many questions for one study, but someday maybe we'll have these definitive answers.